As the president of the DFoot International, I have great pleasure in accepting this invitation to speak on the invitation of our Regional Council member, Dr. Norina from Romania. And what I'm going to do in the next 8 to 10 minutes is to talk to you mainly on offloading and how we in the developing world have developed offloading devices for diabetic neuropathy. So my topic is going to be for 10 minutes on limb salvage in people with diabetic foot ulcers. I have no conflict of interest for this talk. Now, first of all physicians must know when you're planning treatment that there is a stage when the foot is normal, the sensations are normal, the peripheral arterial pulsations are felt, and so on. And then comes a stage when there is deformity in the feet, or loss of protective sensation, or peripheral arterial disease, when you call it a high-risk foot. And then you get a stage 3 where an ulcer develops. The ulcer can get infected in stage 4, and in stage 5 you can get frank gangrene. And in stage 6 you can get gangrene of the entire foot. Now this happens in mostly among people with diabetic neuropathy. Now, it is not necessary to have high-level gadgets. In the developing world, we depend mainly upon the history of neuropathy, which is peripheral neuropathy or peripheral arterial disease. Even in the secondary care, we can depend on the symptomatology. We do a clinical exam with the ankle jerk, with the temperature sensation testing, vibration perception testing, and you make a diagnosis in the primary care and in the secondary care. We can use the vibration perception or monofilament. The electrophysiology is needed only in advanced and clinical research setting and not for primary care and secondary care. So if you have loss of protective sensation, if you have absent dorsalis pedis and posterior tibial pulse, if you have a deformity in the feet, if you have a past history of an ulcer or a pre-ulcerative callus, if you have a history of a prior amputation, or on examination you find limited joint mobility in the feet, then anyone qualifies for a diagnosis of high-risk feet. So it's very important to know this point, because when you talk about limb salvage, this is very important to understand. Professor Andrew Bolton always says that the person with diabetes is often divorced from his feet because he's not able to see them because of blindness, retinopathy, cataract, and so on, and unable to also feel them because of neuropathy. This was a study which we published in an Indian journal way back in 1999, where we found that most of the problems related to diabetic foot occur in people with a level of education which is lower and also a lower socioeconomic status. Now, once you get an ulcerated foot, you have different options which are listed out here: mechanical control, wound control, microbiological control, vascular control, metabolic control, and education control. So these 6 control systems are responsible for healing of a diabetic foot ulcer and limb salvage. And these were proposed by our colleagues from King's College, London. I have been part of the IWGDF guidelines since 10 years. And even this year, I was in the panel which wrote about the offloading and wound healing guideline. This is 2019 guidelines. The 2023 guidelines will be released on May 13th in Netherlands, in The Hague. This is a common problem in developing countries like India, where people try to wear inexpensive footwear. And in the next 4-5 minutes, I'll talk about how we developed offloading for neuropathic feet. So this is a very common problem. People wear this V-shaped, we call it chappals in India, and they get lesions like this, which need debridement and amputation of the toe, and so on. Therefore, about 25 years ago, we started manufacturing our own footwear for offloading. And this is a picture taken recently from our footwear manufacturing unit in Chennai, India. Now, for people who have diabetic neuropathy, it's important that we provide a counter, a soft insole, and also a soft upper with no stitches or anything which will hurt the insensate feet. So we have this for about 10 to 15 US dollars. And we provide it for people who have diabetic neuropathy or loss of protective sensation, stage 2 of the diabetic foot. Now, we tested and we published some years ago in 2004, along with colleagues from the Central Leather Research Institute in Chennai. We found out that those who were wearing these footwear among people who had neuropathy, we were able to show a reduction in pressure, plantar pressure, compared to people who did not wear these footwear. So these insole materials which we used was quite useful to reduce the pressure and prevent ulceration. Now, people who have an ulcer, we use the felted foam to offload the pressure, and this is appearing in the IWGDF guidelines on offloading. We can either put a felted foam like this or apply a felted foam to the insole. So this is for people who have a callus or an ulcer and those who have mild Charcot deformity of the feet and you have a flat foot. You can use a felted foam either this way or this way to offload the forefoot ulcer or midfoot ulcer. People who have Charcot foot, more advanced Charcot foot with deformity and an ulcer like this, on top of neuropathy, need special footwear. So we give ankle high or knee high offloading devices, which we make in our unit, and it costs about 20 to 25 US dollars for making one such device. So we put it on and patients are asked to offload the feet and it works well. We have some data to show that it works well for people who have Charcot foot deformity. The total contact cast is a non-removable type of permanent cast, which we apply for people if they don't have peripheral arterial disease or infection or an ulcer. We do a total contact cast, and that has also been recommended by the IWGDF guidelines. Lastly, let me tell you that it's very important to prevent peripheral neuropathy or diabetic peripheral neuropathy, DPN. And for that, it's very important to control diabetes. So for all the physicians, diabetologists, endocrinologists who are attending this talk, I think it's very important that we control the A1C to below 7%. We keep it at 6.5%. And also avoid the glycemic variability, which is seen among people with diabetes. Even if the HbA1c is 7.2%, you can get glycemic variability, a high intraday, interday variability. So the A1C in some of the studies were found to vary from 8.5% to 9.3%. So this is not acceptable. You have to keep diabetes under control, and only then we can prevent diabetic peripheral neuropathy. I would like to thank once again all of you for your kind attention, and particularly thank our regional counsel from Europe, Dr. Narina Gavin, for asking me to give this talk. Thank you for your attention.